Let's jump right in. Our first condition, prerenal azotemia.
Okay. The mechanism here is a fundamental decrease in renal blood flow.
Okay, less blood to the kidneys.
Exactly. Think of your kidneys like this powerful water filter for your blood. If less blood flows through them, that filtration rate, how efficiently they clean it, drops.
Right.
The kidneys then, they panic, sensing a lack of fluid, and they start desperately holding on to everything: water, salt, even waste products like urea.
And that's exactly what happened with Mrs. Rodriguez. Her caregiver called us about this.
Okay.
She had been drinking much water for days, thinking it would help with swelling from her heart failure. But instead, well, she started feeling really lightheaded and weak.
Yeah. Low flu state.
Exactly. At the hospital, her blood pressure was low. Doctors quickly realized her kidneys just weren't getting enough blood. They were trying desperately to hold on to every single drop.
That conservation mode.
Yes. And this acute attempt to conserve was starkly visible in her labs. Her urine was incredibly concentrated, almost like thick syrup, indicated by a high urine osmolality, over 500.
Very concentrated.
And her kidneys were holding on to salt so tightly that her urine sodium was really low, under 20. Plus, her BUN creatinine ratio, a key marker, was high, over 20.
Classic signs.
That confirmed the diagnosis. So they immediately started IV fluids, which is the key management, right?
Absolutely. Restore the volume.
And she felt much better. Within a day,
Yeah.
her kidney numbers started improving.
Yeah, what's insightful there is that her kidneys themselves weren't damaged. Not intrinsically, they were just underperfused. It's a functional problem, often quickly reversible if you catch it. The highly concentrated urine, the low urine sodium that's the kidney's desperate cry for help, a clear sign you need to restore that blood flow.
That was a powerful example. External factors hitting internal organs. But what happens when the problem starts inside the organ?
Right.
Our next condition, intrinsic renal failure.
Okay, so here, this involves direct damage to the kidney's filtering units, specifically patchy necrosis.
Necrosis,
Yes.
cell death.
Yes, sections of those tiny tubules die off. The dead cell debris then obstructs the remaining tubules, causing fluid to back up, which ultimately, well, it tanks the glomerular filtration rate.
Right, clogs the system from the inside.
Yeah.
A clinician shared the case of John, admitted with a severe bloodstream infection.
Sepsis, common trigger.
Yeah. A few days into treatment, his kidney function rapidly declined and his urine output just dropped significantly. The doctors explained the severe infection had directly damaged those tiny filtering tubes in his kidneys, causing this patchy necrosis.
Okay.
And under the microscope, they found muddy brown casts.
The classic finding. Very specific.
Highly characteristic, right, for this type of kidney failure. His labs also showed his kidneys couldn't concentrate urine anymore. Low urine osmolality and high urine sodium.
Makes sense. The machinery's broken.
Exactly. Because the damage meant they couldn't control water and salt balance.
Yeah.
They actually had to use a special machine, dialysis, to filter his blood. But his kidneys eventually recovered as the infection cleared. Avoiding medications known to be tough on kidneys, those nephrotoxic drugs, is also crucial here.
So, very different from prerenal, where the kidney is just thirsty. Here, the plumbing itself is broken.
Yeah.
Those muddy brown casts are literally the debris from the damaged kidney cells, a really distinct differentiator. And that inability to concentrate urine tells you the kidney's internal machinery is profoundly impaired.
Okay, from internal damage, let's talk blockages. Next up, postrenal azotemia.
Right. The mechanism here is simpler, in a way. It's just an outflow obstruction.
Like a clogged drain.
Exactly. Imagine a drain that's completely clogged. This typically has to be bilateral, affecting both kidneys, or unilateral if a patient only has one functioning kidney, to cause significant problems.
Got it. Imagine Mr. Davies, an elderly gentleman. He comes to the ER with severe lower abdominal pain, difficulty urinating for a day, and also lower back pain.
Okay, sounds uncomfortable.
Yeah, and his bladder was noticeably distended. Felt like a hard balloon on exam.
The telltale sign.
The doctors quickly realized his enlarged prostate was acting like a dam, completely blocking the flow of urine from both his kidneys.
Right, causing back pressure.
Exactly. It caused a buildup of pressure that drastically reduced kidney function. But once they placed a catheter to drain his bladder, immense, immediate relief.
Instant fix, almost.
And his kidney function started to recover quickly.
Yeah.
So this case really emphasizes that identifying and treating the underlying obstruction, removing that dam, is the primary management, along with, still avoiding any drugs that could further stress the kidneys.
Yeah, this is often the most straightforward of the kidney issues once you identify it. remove the blockage, and the kidney function can bounce right back. That distended bladder is often the key diagnostic sign. It's purely mechanical.
Okay, shifting gears from kidneys to a sudden acute gynecological emergency. Adnexal torsion.
Ooh, yeah, this is serious. It's the twisting of an ovary, or sometimes the fallopian tube, around its supporting ligaments. Yeah, and it's a cascade. First, it kinks off the veins and lymphatic drainage. That causes swelling, engorgement.
Huh.
Then, as it twists tighter, it eventually blocks the arterial inflow, cuts off oxygen, and that leads to tissue necrosis, tissue death.
Wow. Sarah was at the gym when she was suddenly hit with just excruciating sharp pain in her lower right abdomen.
Sudden onset, classic.
Came out of nowhere. So intense it made her nauseated. At the ER, the doctor found a tender mass on her right side during the exam.
The swollen ovary.
The concern was immediate. Her ovary might have twisted, cutting off its blood supply. This sudden twisting causes that acute, severe pain. And the initial venous congestion leads to the swelling and that palpable mass the doctor felt.
Right.
They rushed her to surgery to try and save it. Immediate surgical intervention is crucial to restore blood flow and prevent permanent tissue death.
Excruciating sharp pain that came out of nowhere that really paints a picture. Sounds like something requiring incredibly fast thinking. And the variable presentation of pain sometimes means high clinical suspicion is absolutely vital because every minute counts in trying to save that ovary.
Okay, from acute pain to a critical condition in pregnancy, preeclampsia.
Right. Its mechanism involves abnormal development of the placental spiral arteries. Those are the blood vessels supplying the placenta.
Okay, something wrong with the placenta's plumbing.
Basically, yeah. This leads to widespread endothelial dysfunction throughout the mother's body, causes excessive vasoconstriction, ischemia.
So blood vessels tightening up everywhere.
Pretty much. And it ultimately manifests as new-onset hypertension, high blood pressure, along with proteins spilling into the urine.
Okay. During her third trimester, Maria started having really bad headaches, blurry vision, and her hands and feet were much more swollen than usual.
Concerning symptoms.
At her prenatal appointment, her blood pressure was dangerously high, and they found a lot of protein in her urine.
There's the triad.
The doctor immediately said, "This is preeclampsia." She explained something was wrong with the blood supply to Maria's placenta, and it was affecting her entire body. So that key triad, new hypertension, we're talking over 1490, proteinuria in being over 20 weeks gestation, that's a diagnostic.
Right.
They started magnesium sulfate immediately to prevent seizures.
Crucial step.
Yeah.
Neuroprotection.
And discussed needing to deliver the baby early, because delivery is the definitive treatment to keep both mother and baby safe.
Yeah, this condition really underscores how profoundly the placenta impacts the mother's body. It's not just high blood pressure, it's a systemic dysfunction. And the possibility of HLLP syndrome, a severe variant affecting the liver and blood. That's why vigilance is so critical.
Staying with pregnancy, let's explore supine hypotensive syndrome.
Yes. In the supine position, that means lying flat on your back, the gravid or pregnant uterus, especially later on.
The weight of the baby.
Exactly. It directly compresses the abdominal aorta and the inferior vena cava, the big vein returning blood to the heart. This dramatically decreases blood flow back to the heart and also affects blood flow to the placenta.
So during her prenatal visit, while lying on her back for an exam, Elena suddenly felt dizzy, lightheaded, and nauseated. Her heart started pounding.
Classic symptoms.
The nurse quickly helped her turn onto her side, and within moments, the feeling passed.
Simple fix?
The doctor explained that her growing baby was pressing on those major blood vessels, the vena cava and aorta, when she was flat on her back. Made her blood pressure drop, affecting blood flow to both her and the baby.
Highlights the literal physical compression.
Exactly. Elena was advised to avoid lying directly on her back, especially when sleeping, and to always sleep on her side. That's the direct, immediate, effective management. Just relieve the compression.
It's a mechanical issue with a simple fix, really. The key is recognizing it and understanding why turning onto the side works. It literally moves the uterus off those critical blood vessels.
Okay, moving to polycystic ovary syndrome, or PCOS.
Right. Its mechanism often involves hyperinsulinemia and and/or insulin resistance.
Problems with insulin.
Yeah. This alters the delicate feedback loop in the brain's hypothalamus. It leads to an increased ratio of luteinizing hormone, LH, to follicle-stimulating hormone, FSH.
And hormones get out of balance.
Exactly. This imbalance then drives increased androgen production male hormones by the ovaries. And ultimately, you get unruptured follicles and anovulation, meaning eggs aren't released properly.
Okay. So for years, Maria struggled with irregular periods, severe acne, and noticeable facial hair growth.
Classic signs of hyperandrogenism.
She also found it incredibly difficult to lose weight. When she and her husband tried to conceive, they faced repeated disappointments.
The anovulation impact.
Her doctor eventually diagnosed her with PCOS, explaining her body's insulin resistance was messing up her hormones, causing her ovaries to make too much male hormone and not release eggs properly. This results in the characteristic cysts seen on ultrasound, which are actually those unruptured follicles. So this core dysfunction, with that high LH to FSH ratio, it explains the anovulation, the hyperandrogenism, and that polycystic appearance on ultrasound that define PCOS.
Yeah, what's crucial to understand here is the central role of insulin resistance. It's not just a metabolic issue, it's a hormonal cascade affecting reproductive function.
Right.
Addressing the insulin resistance, often through lifestyle changes like diet and exercise, can be a real cornerstone of management.
Okay, so from too much hormone activity, let's talk about the opposite. Functional hypothalamic amenorrhea.
Right. This is triggered by things like severe caloric restriction, maybe increased energy expenditure, or significant psychological stress.
So the body under stress.
Exactly. These factors alter the pulsatile secretion of gonadotropin-releasing hormone, GnRH, from the hypothalamus. That then leads to decreased levels of LH, FSH, and consequently estrogen.
The whole system dampens down.
Precisely. After joining the track team, Emily became obsessed with her diet and training, running 10 miles daily, drastically cutting calories.
Okay, high stress, low energy intake. Yeah. Within a few months, her periods, which had always been regular, completely stopped.
Amenorrhea.
Her doctor explained her body was under so much stress and wasn't getting enough fuel that it had to essentially shut down her reproductive system to conserve energy.
Survival mode.
Exactly.
Yeah.
This suppression of the GnRH pulsatility, which normally signals the ovaries, and the subsequent low LH, FSH, and estrogen, that's the core mechanism. Emily was advised to increase her caloric intake and slightly reduce her training intensity, directly addressing the underlying causes.
Yeah, this beautifully illustrates how profoundly the body prioritizes survival. When it perceives an energy deficit or extreme stress, reproduction becomes, well, a luxury it feels it can't afford. It's a remarkable, albeit sometimes problematic, adaptive mechanism.
Now let's turn our attention to men's health and a condition called varicocele.
Okay, this is caused by dilated veins in the pampiniform plexus. That's a network of veins around the testicle.
Dilated veins, like varicose veins elsewhere.
Exactly like that, yeah. Due to increased venous pressure. And this leads to an enlarged scrotum, usually on one side.
Okay. Mark and his wife have been trying to conceive for over a year without success.
Infertility concern.
Yeah. Mark had also noticed a feeling of heaviness and a peculiar bag of worms sensation in his left scrotum, especially after a long day on his feet.
Ah, the classic description.
During a fertility workup, the doctor examined him and immediately identified a varicocele. These dilated veins in the pampiniform plexus easily felt on physical exam, especially when standing or doing a Valsalva maneuver.
Increases the pressure.
They were increasing the temperature in his testicle and affecting sperm production.
That's the key link to infertility, heat sensitivity.
Right, making it a common and often correctable cause of male infertility. Addressing the varicocele, often surgically, is a potential intervention for improving fertility.
Yeah, the bag of worms description is classic for a reason. It's a very distinctive finding on exam. The crucial insight is that impact of increased temperature on sperm production. It's a reminder of how sensitive our body's systems are to seemingly small environmental changes.
Okay, next, a fascinating one, methemoglobin.
Ah, yeah. Methemoglobinemia. Its mechanism is the oxidation of hemoglobin, usually secondary to certain agents like dapsone, some local anesthetics, or nitrites.
Oxidation, changing the iron.
Precisely. The ferrous iron, Fe² in hemoglobin, which normally carries oxygen, gets converted to ferric iron, Fe+.
Okay.
This significantly decreases hemoglobin's ability to bind and release oxygen effectively, leads to tissue hypoxia, lack of oxygen in tissues, but interestingly, it increases cyanide affinity.
Strange twist. Okay, so during a dental procedure, Mr. Henderson received a new type of local anesthetic.
Common culprits there.
Halfway through, the dental assistant noticed his lips and fingertips were turning a strange bluish-gray color. much darker than normal cyanosis.
Chocolate cyanosis, they sometimes call it.
Right, even though his oxygen levels seemed okay on the pulse oximeter.
But that's the confusing part. The monitor can be falsely reassuring.
Exactly. The dentist, recognizing the unusual cyanosis, quickly called for emergency help. Paramedics immediately suspected methemoglobinemia from the anesthetic. Explained his blood wasn't able to carry oxygen properly because of that change in his hemoglobin. They administered an intravenous medication, methylene blue.
The antidote.
The common antidote, yeah. And within minutes, his color began to return to normal.
A bluish-gray color with good O2 sat readings. That's truly counterintuitive and, frankly, almost frightening.
Definitely.
It really highlights how complex blood chemistry is beyond just enough oxygen. It's about effective oxygen delivery.
Yep.
And vitamin C is another treatment option sometimes used.
Okay, let's delve into deep venous thrombosis, or DVT.
Right. This is the formation of a blood clot in a deep vein. It's governed by Virchow's triad.
Virchow's triad. Remind us.
Sure. It's 3 factors. Stasis, meaning sluggish blood flow, hypercoagulability, an increased tendency for blood to clot, and endothelial damage, which is injury to the inner lining of the blood vessel.
Got it. Stasis, hypercoagulability, endothelial damage. So after her knee surgery, Mrs. Chen was recovering at home.
Okay, surgery, a big risk factor, immobility, vessel injury.
Exactly.
No.
3 days later, she woke up with a dull ache in her left calf that quickly turned into a throbbing pain. The legs started to swell, felt warm to the touch, looked a bit red.
Classic DVT symptoms: unilateral leg swelling, pain, warmth.
Her daughter insisted they go back to the hospital. The doctor immediately suspected a DVT. He explained that lying still after surgery, that's stasis, combined with the surgical trauma itself, endothelial damage, created the perfect conditions for a clot to form. Fits Virchow's triad perfectly.
Yep.
They started her on blood thinners right away to prevent the clot from traveling to her lungs.
The dreaded pulmonary embolism, that's the major risk.
Absolutely. Early mobilization after surgery and heparin prophylaxis. Those preventative blood thinners are crucial prevention strategies, especially post-op.
Yeah, Virchow's triad is such a cornerstone here because it helps us identify patients who are at risk and really understand why prevention is so critical. A DVT isn't just a localized leg problem. It carries that very real risk of PE.
Okay, our next condition, sarcoidosis-associated hypercalcemia.
Right. The mechanism here involves non-caseating granulomas. These are characteristic clumps of inflammatory cells found in sarcoidosis.
Okay, inflammation clumps.
Yeah, with increased macrophage activity within them. These active macrophages have increased 1-alpha hydroxylase activity. That's an enzyme that activates vitamin D.
So the inflammation activates vitamin D.
Exactly, way too much of it. This activated vitamin D then significantly increases calcium absorption from the gut and release from bone, leading to high calcium levels in the blood, hypercalcemia.
Okay, Mr. Thompson had been diagnosed with sarcoidosis, but recently felt unusually tired and confused. Complained of stomach aches, lost his appetite, and was drinking enormous amounts of water. Really thirsty.
Polydipsia, confusion, GI upset. Sounds like hypercalcemia symptoms?
His blood tests showed alarmingly high calcium levels. His doctor explained the inflammatory clumps, the granulomas from his sarcoidosis, were overactivating vitamin D in his body, causing his bones to release too much calcium and his gut to absorb too much.
Right.
This is the classic stones, bones, moans, groans, and psychiatric overtones often associated with high calcium.
It's a good mnemonic.
They immediately started IV fluids, the first-line acute management for hypercalcemia,
Dilution and excretion.
and glucocorticoids, steroids, to reduce the granuloma formation and lower that vitamin D production, addressing the underlying sarcoidosis.
Yeah, what's really remarkable here is how an inflammatory disease like sarcoidosis can directly hijack a vitamin pathway, leading to a seemingly unrelated problem like dangerously high calcium. It shows the incredible interconnectedness of our immune and endocrine systems.
Definitely. Approaching the end now with acute respiratory distress syndrome, or ARDS.
ARDS, a very serious lung condition. It begins with alveolar injury damage to the tiny air sacs and widespread inflammation in the lungs.
Okay.
This leads to capillary endothelial damage and increased vessel permeability. Basically, the lungs' blood vessels become leaky.
Leaky vessels.
Yeah, leaking protein-rich fluid into the alveoli, those air sacs.
Yeah.
This fluid forms hyaline membranes and causes what we call non-cardiogenic pulmonary edema fluid in the lungs, not caused by heart failure.
So the lungs fill with fluid.
Right. Right. They become stiff, compliance decreases, there's a mismatch between ventilation, air getting in, and perfusion, blood flow. You get hypoxic vasoconstriction, all culminating in severe oxygen deprivation.
Wow. Mr. Rodriguez was healthy until he developed a severe, overwhelming pneumonia.
Common trigger for ARDS, sepsis, pneumonia.
Within a day, he was struggling to breathe, gasping for air. His oxygen levels plummeted despite being on high oxygen.
Refractory hypoxemia doesn't respond well to oxygen.
His chest x-ray showed widespread white patches in both lungs, bilateral infiltrates.
They're white out lung.
Doctors explained his body's severe inflammatory response to the infection had damaged the tiny air sacs in his lungs, causing them to fill with fluid and become stiff. They called it ARDS, characterized by that acute hypoxemic respiratory failure, the bilateral infiltrates on x-ray, and importantly, a normal pulmonary capillary wedge pressure.
Right, distinguishing it from heart failure edema.
Exactly. They had to put him on a ventilator using a special lung protective strategy, low tidal volumes, using PEEP,
Positive and expiratory pressure.
to gently inflate his damaged lungs while his body fought the infection.
Yeah, ARDS is such a critical scenario where the lungs essentially drown in the body's own inflammatory response. That lung protective ventilation strategy is all about minimizing further ventilator-induced injury while the body tries to heal. Very challenging.
Absolutely. Finally, let's round out our deep dive with sleep apnea.
Okay, sleep apnea. It comes in two main forms. There's obstructive.
Obstructive sleep apnea, OSA.
Right, where there's respiratory effort, the person's trying to breathe, but it's against a physical airway obstruction, usually the throat collapsing.
Okay.
And then there's central sleep apnea.
Central from the brain.
Exactly. Impaired respiratory effort because of CNS injury or toxicity, maybe congestive heart failure or sometimes opioids. The brain isn't sending the signal to breathe properly, and obesity is a major contributing factor to obstructive sleep apnea.
Right. So for years, David's wife complained about his incredibly loud snoring
Common sign.
and how he would suddenly stop breathing for long periods during the night, only to gasp loudly for air afterwards.
Apneic episodes with resuscitative gasps. Classic OSA.
David himself was always exhausted during the day, falling asleep at work, even at traffic lights.
Excessive daytime sleepiness. Another hallmark.
He also developed high blood pressure that was really hard to control.
The systemic consequence. Chronic hypoxia takes a toll.
A sleep study, the gold standard diagnostic test, confirmed severe obstructive sleep apnea. It explained his airway was repeatedly collapsing while he slept, literally depriving him of oxygen, and that chronic lack of oxygen from OSA contributed significantly to his hypertension. Getting a CPAP machine
Continuous positive airway pressure.
was a game changer. Keeps his airway open with positive pressure. Weight loss and avoiding sedatives and alcohol before bed, those are also crucial management strategies.
Yeah, the daytime exhaustion and that difficult-to-control high blood pressure are such classic red flags for sleep apnea. It's a condition often dismissed as just snoring, but its systemic effects, especially on the cardiovascular system, are really profound. Needs to be taken seriously.
Wow, what a journey through 14 distinct conditions. That was rapid fire.
It really was.
From the subtle fluid shifts of prerenal azotemia, to the dramatic twisting of Adnexal torsion and the invisible struggles of sleep apnea, we've really seen how understanding the why, the mechanism, makes the what and how so much clearer. You, our listener, now have, I hope, a solid foundation for each of these.
Indeed. Each story provided, I think, a memorable anchor for some complex medical concepts, demonstrating how a clear grasp of mechanism directly translates to recognizing symptoms, making a diagnosis, and guiding effective management.
Yeah.
The common thread is always critical thinking and, attention to detail, which raises an important question for you, the listener.
Ooh, okay. And for you, our dedicated listener, we hope this deep dive hasn't just given you facts, but maybe a framework for curiosity. Here's a provocative thought to mull over. How might a single lifestyle choice like, say, diet or exercise, unexpectedly influence multiple seemingly unrelated conditions we discussed today? Think about PCOS, maybe even DVT risk, sleep apnea. What does that tell us about holistic health?
That's a perfect thought to leave us with. It really underscores that the human body is this incredible tapestry of interconnected systems. Understanding those threads is key.
Absolutely.
Until next time, keep exploring, keep questioning, and keep making those connections.
Absolutely. Stay curious, stay informed, and we'll see you on the next deep dive.